Live.
So now we start.
Yeah, we can start. How many people are there in the? Can we make out how many people are already there? The participants.
Abhishek,
are there.
Sorry?
20 have already started there, viewing there.
Okay, so we'll wait till at least it becomes 50.
Yes, sir.
So let us know when it becomes 50. And definitely not beyond 2-5. So whichever comes first, we will start. So Pradeep, you are going to start or I am supposed to start?
so I am supposed to start.
And then?
I'll be introducing this series webinar, and then I'll introduce Dr. Pradeep Agarwal. He will be giving the welcome note. Then we will have the video.
Okay. Then after the video, I join.
Yes, sir.
Okay, good.
जब 50 हो जाता है बताना.
Yeah, live.
Why don't you start, Maheshwata? I think we should start.
Yes, sir. So good afternoon, everyone. We welcome you to the first of the MINErVA webinar series organized by All India Institute of Medical Sciences, New Delhi and All India Institute of Medical Sciences, Rishikesh. Dr. Pradeep Agarwal spearheaded the organizing team and has come up with a wonderful webinar series that we will be having quite a few of them in next every few months. So I hereby welcome Dr. Pradeep Agarwal, Associate Professor of Department of Community and Family Medicine, AIIMS Rishikesh, to start the session with a welcome note. Dr. Pradeep Agarwal.
Thank you very much, Maheshwata. On the behalf of AIIMS family, New Delhi and Rishikesh, we welcome you all for this webinar series. And over a period of next 1.5 hours, you will understand how the MINErVA have taken up a lead and helped the Government of India, Registrar General of India, and one of the important component of verbal autopsy that need to be relooked, re-emphasized during this webinar is going to take up by the eminent speakers, Madam Rohina Joshi and Biju Soman sir. So back to, without wasting much of our time, Maheshwata, can we have a glimpse of the program?
वो फॉर्म लिंक मांगे प्री टेस्ट और पोस्ट टेस्ट का तेरे को ब्यूटीफुल।
So we will be having, this is the agenda of the program that we will be visiting throughout the next 1 hour. This is the agenda of the program. So this is the agenda of the program, of today's program, and we will be having a wonderful afternoon with all the eminent speakers, and we will get to know a lot about MINErVA and the current associated matters related to it. So we will be next viewing the MINErVA video, which will give us a glimpse on how the MINErVA started and where we are presently. So kindly share the video. Welcome to MINErVA, Mortality in India Established Through Verbal Autopsies. Why do we need MINErVA? Reliable statistics on the causes of death in the population are essential for setting priorities in the health sector. In India, where adequate medical facilities are not available, most people do not die in health facilities, so cause of death is unknown. Data based on the medical certification of cause of death is insufficient to represent the whole country accurately. However, the sample registration system is an important source of data on annual demographic indicators, including causes of death in India. It is based on a system of dual recording of deaths in fair. Physicians to ascertain the underlying cause of death. It is here that MINErVA comes to play an important role. All India Institute of Medical Sciences, New Delhi, partnered with the Office of Registrar General of India to accomplish a common goal: reliable estimate of cause of death in India through MINErVA. Who are we? The MINErVA as a network comprises of AIIMS Technical Support Unit, network institutions, physician coders, and technical advisory group. AIIMS Technical Support Unit, located at AIIMS New Delhi, include faculty members and project staff. It closely liaises with Office of Registrar General of India in implementing the program and provides technical support. Presently, we have 25 reputed medical colleges across the country as partner institutes to ATSU in the MINErVA network, and it is an ever-expanding process. Through MINErVA network, we provide introductory as well as refresher training to supervisors regarding the verbal autopsy. Physician coders are the heart of the MINErVA network. Technical advisory group includes experts in the field of epidemiology, clinical sciences, demography, and statistics, and has an advisory role. The entire process of information collection from the verbal autopsy, data quality checks, and assignment of ICD codes by physicians is done through a web-based application developed by the ATSU. The web application of MINErVA has 3 platforms. The QA platform for quality assurance of verbal autopsy forms. Training platform provides an online training to the physicians regarding the assessment of cause of death based on verbal autopsy and guide them to provide most appropriate ICD-10 codes for the same. Online coding platform enables the physician coders to visit the verbal autopsy form allocated to them and provide the appropriate code. From the humble beginning, the MINErVA network has grown rapidly and expanded to its present avatar. Today, the network is functioning smoothly. Causes of death have been assigned for over 1,25,000 deaths enumerated by the SRS between 2015 to 2017, thereby fulfilling an important public health function. With the constant support of the partners, we have set our long-term goal of each and every death being counted and cause of death ascertained, death within the hospital as well as outside. We strive to accomplish this by strengthening medical certification of cause of death with collaboration of medical institution, National Medical Council, as well as private hospitals. The other aspect is to increase the coverage of verbal autopsy to cover the entire non-hospital death in the country through expansion of SRS and including verbal autopsy as a part of the health system at all levels. Both these actions will provide us with substantiate data and help making policies regarding health and its infrastructure. We take this opportunity to invite you to join in this public health initiative. Thank you. So this is how the MINErVA was born and its development as of now. And as seen, it is an ever expanding process, and we will be seeing many more network partners, many more coders joining hands and helping us to get the data that we need for the cause of death ascertainment. So next, I welcome Dr. Anand Krishnan, Professor of Center for Community Medicine, New Delhi, who has been at the center of the birth, growth, and development of MINErVA.
Thank you, MINErVA. So we all just saw the short film on MINErVA, which is mortality in India established through verbal autopsy. As you have just been told, MINErVA was born at AIIMS New Delhi in collaboration with RGI to strengthen the cause of death system in India. Primarily starting with verbal autopsy, but we would also move to other areas like medical certification of causes of death, etc. Every public health person worth his or her salt knows that this is an essential need for a public health planning. Cause of death data is a must in for any public health planning. And unfortunately, in the Indian context, we really cannot say that that is happening properly or as we would like it to happen. And therefore, this that's the main agenda or goal of this MINErVA, that we strengthen the mortality surveillance so that we generate data on cause of death, if possible by state and district level, but definitely at national level. So with that in mind, we created this network of institutions, which are currently stands at about 25, and as already said, it is expanding. And through this, we have started this webinar series to increase the awareness about this, not only MINErVA, but also increase the awareness and understanding about mortality surveillance, including cause of death in the Indian public health fraternity. For today's, and we will be continuing to hold this series of webinars. Today is the first webinar, and we are happy that it is hosted along with us by AIIMS Rishikesh, which is Dr. Pradeep Agrawal's support. And we have two excellent speakers to start with, and both are already, can you go to the next one? Both are already associated with MINErVA as our advisors, as a part of our technical advisory group. And in our last meeting, we realized that we have so much expertise within the group, technical advisory group, that it will be criminal if we don't start sharing it with others. And keeping with that in mind, we have two speakers today who will both look at integrating verbal autopsy into civil registration systems, or CRS, or CRVS, or civil registration vital system. So, and the first speaker is Rohina Joshi, who is currently, and she recently joined as associate professor in the University of South Wales. As you can see, she is extremely accomplished and has a lot of work in the area of verbal autopsies. And she's also a senior technical advisor for Bloomberg Philanthropies funded Data for Health initiative. And she has done some excellent work on using verbal autopsy methods and in large-scale systems and how to integrate them both in India and China. I'm sure she has a lot of her expertise to share with us, and it will be our pleasure and privilege to hear her speak. The next speaker is Dr. Biju Soman. He's a professor at the Achyuthamenon Center for Health Sciences at Sri Chitra Tirunal Institute of Medical Sciences, Trivandrum. He is an MD in chemistry medicine, and I know him personally as he has extremely high advanced interest in health informatics and bioinformatics, and does a lot of those kind of work. But he also works in the area of verbal autopsies. He's the coordinator of the field practice area of Ati Noor of Sri Chitra Tirunal, AMCHS, and he's worked closely with verbal autopsies and computer codings of verbal autopsies and physician codings. And we are also privileged to have him as a member of our technical advisory group. And I'm sure we will learn from both of these people. I will now invite Dr. Rohina Joshi to share her presentation. I would request the participants, if they have any question, to please put it in the chat box, and request MINErVA to identify the key questions and direct them to me so that we can have a good discussion subsequent to the presentations. So, Rohina, the floor is yours, and we have about 25 minutes for you.
Thank you so much, Professor Krishnan. Thanks all, and thank you to the MINErVA organizing team for giving me this opportunity to present some of our work today. So what I'm going to talk today about is integrating community-based verbal autopsy into civil registration and vital statistics. And this is basically lessons learned from 5 countries. So in terms of the background and aims, I'm going to begin by just describing the lessons. So the aim of this is to describe the lessons learned from the rollout of Smart VA, and Smart VA is one of the many verbal autopsy methods which is available today. So it was lessons learned from the rollout of that particular method in China, Myanmar, Papua New Guinea, Philippines, and the Solomon Islands. So this was a part of the Data for Health initiative, which is funded by Bloomberg Philanthropies and the Department of Foreign Affairs and Trade of Australia. In terms of the partners, each country each country was led by their Ministry of Health and the National Departments of Health and a range of other departments, but these 2 drove the process. And in terms of international partners, University of Melbourne, Vital Strategies, Center for Disease Control, Bloomberg Philanthropies, and DFAT were the international partners. So as I said, all of these 5 countries used Smart VA method, which was developed by the Population Health Metrics Research Consortium and validated in several countries, including India. And what this tool basically has is a shortened verbal autopsy instrument, an analytical software called Smart VA Analyze, which uses Tariff 2.0. And using these 2, it provides a cause of death. So my presentation is based on this paper, which was just published last week. For further details, please feel free to refer to this paper, which was published in BMJ Global Health. So in terms of the methods, what we've done is each of these countries started up Smart VA and integrated it into CRVS about 5 years ago. And what we are doing now is looking at it from a systems lens to understand the implementation of verbal autopsy in CRVS. And what we do is we look at the system level features that need to be considered for the successful implementation of VA. And this paper is based on Professor Don D. Savigny's led paper, which looked at how, at the beginning of this project, how do you plan things and how do you look at different system level domains? And so now, after 5 years, we're looking back at those system level domains to say what worked and what were the lessons we learned in each of those domains around governance, human resources, financing, logistics, quality assurance. So I'm hoping over the next 15, 20 minutes, I can take you through this from a very generic perspective. Talking through 5 countries in 20 minutes just does not give it justice, but I will take you through just the generic, those broad those domains. So when Professor D. Savigny and colleagues wrote that original paper, their planned process to integrate VA into CRVS looked a bit like this on paper, wherein when a death occurs, the community key informant would assist the family to notify the death. And so if you look at the little hut over here, the death gets notified, the family informs the local authority. From there, the data gets transferred to a central database. That is the death notification. Once that central database has that particular death available, what happens is that they send the message to the health facility to inform them that, look here, a death has occurred in village X, please do a verbal autopsy. So basic information ideally should be pre-populated in the questionnaire, and the health worker, be it a community health worker, a midwife, or a nurse, would then go to the family and interview the relative of the deceased using a portable computer like a tablet. This information is then sent back to that central server, which then analyzes the causes of death using tariff or InterVA or any of those methodologies to then provide a population-based cause of death. So this was the planned process to integrate it. So now, 5 years later, we now look back at how that integration occurred and what were those domains and what were the lessons learned from each of the domains. And I'll begin with the first, which is the most important aspect of it, being governance. In such a large scale project, the most important part of that project is around a needs-based initiative, which needs to be led by the country. That ownership has to come from the Ministry of Health or, whatever the department is responsible for the, for capturing births and deaths, but also for planning health programs. All of the countries that participated in the Data for Health initiative, they are signatories to the United Nations SDGs to improve notification, registration, and causes of death by 2030. And again, all of this aligns with the targets of the WHO's call for universal civil registration of births and deaths and improving causes of death. It also aligns with the targets of the World Bank as well as United Nations Economic Social Commission in the Asia Pacific. So, all these governments had to kind of respond to these different targets, and therefore it was, it was a needs-based initiative. The other aspect of it was the co-design part of it. So it wasn't a technical expert telling a country, hey, this is what you should do, go ahead with it. But it was actually designing that product together to say what product can be used and how can it be implemented in the country. So in a generic sense, this is the governance structure for the Data for Health initiative. Each country it had tweaked a little bit, but basically what we had was a country-based CRVS committee. Now in China, it was slightly different because CDC China led that CRVS, the governance around it. But the main aim of this committee was to oversee how VA and VA data will be integrated into the CRVS processes. Under that committee sat this technical working group, which talked to non-governmental stakeholders like UNICEF or any other NGOs which were working in the same space, as well as the technical advisors. That's where I sat on the D4H technical advisors, and I continue to sit within that particular box. But it was the VA technical working group from the country, which represented many national departments, health, statistics, administration, and their main role was to plan and then to monitor and evaluate the VA implementation and scale up. And then when we look at the implementation, it was basically the health sector in each of the countries that took it up on themselves to collect the data, to supervise the process of data collection, and then use that data in health planning. There were other country-specific CRVS stakeholders, which assisted in the facilitation of VA within CRVS. And of course, the third key implementing part of this team was the statistical office, who analyzed the VA, provided that quality control, looking at the data, and at the end of each year or every 6 months, reported and disseminated that VA information. So this was the broad governance structure across the 5 countries, with a couple of tweaks here and there based on each country. And again, one of the things is that most of the countries that we worked in, or this paper has been based on, have a decentralized system of governance. So in terms of the implementation team, it was the local health units or the local epidemiological bureaus who ran that implementation process. So the next big thing was around design and operational issues. The first part of it was governance that we talked about, the CRVS committee, which basically had to build the business case of running or doing VA and their commitment of VA implementation. The second part was doing business process mapping on death registration. And I'll show a picture of, an example of a business process map. But basically, it was to understand the processes, one, what processes are written on paper, and the other one is about what actually happened on the ground. And, one can't really just do it at a country level, especially in a place which has decentralized system of governance. So we had to look at subnational levels as well. And the other interesting thing is, when you talk to people at a higher level of management, their idea of what happens on death registration is slightly different to actually what happens on the ground. So it is a good idea to work with the team and actually understand, go and visit the sites and see what a family has to do in terms of registering a death and getting a death certificate. We then went to the next phase was pre-test and evaluation. And this was basically, doing cognitive testing and understanding whether our understanding of the questionnaire is the same as that of the interviewer as well as the respondent, but then doing a pre-test on a convenience sample. And this was basically to check translation as well as field testing of the instrument as well as the processes. How would we implement it if it was scaled up? The next was a formal pilot test and evaluation. And this was testing the VA implementation. And this was done on a purposive sample. Coming in from a research background, we want everything to be gold standard, but actually operationally, it's so different. So you end up having a purposive sample where you can use the results. So that was the next stage. And the final stage is scale up using a phased approach in new areas and populations. And across these 5 different steps of the design and operations, one needs to really think of the system changes, whether there is any legislative issues that need to be thought of, the job descriptions that need to be changed of community health workers or midwives, any standard operating procedures, thoughts about the training program, the IT infrastructure. So all of these system level changes had to be thought of in each phase, and from a point of view that whatever changes we bring into place have to be put in for the long run in terms of sustainability. So this is an example of a business process map. On a piece of paper, it's massive when you start off from the family where a death has occurred to that next step of taking it to the community level, the facility, what happens, who receives the information when. What are the different barriers, also to understand what are the barriers at different levels such that people don't get the death registered, and how do we remove them and facilitate that process to enable the registration of deaths and verbal autopsy process to get better causes of death. The next, just in terms of the lessons learned was from the design and operational issues is just have a staged process. It's absolutely essential to have that to build confidence of the team, just for everybody getting comfortable, for the integration of this intervention into the normal workflow, and also to allow for design changes. And we did have design changes in different countries. Flexibility is absolutely key. As I said, not all business processes maps will look the same, even within the same country. And purposeful sampling is, it's an operational reality. And the idea is that once, we do a purposeful sampling, then to think about how those results will be interpreted. As I said, adaptation to VA implementation is absolutely necessary. When we took the smart VA to Philippines, we very soon realized that that's not going to be possible, because in the Philippines, it's the doctors who interview the relative of the deceased and use that interview to actually complete a medical certificate of cause of death. So we could not use the stock standard smart VA. We had to change it slightly such that it's acceptable to doctors. It goes within their workflow, and even in terms of the number of clicks that they have to do in order to get a cause of death, from 5 we reduced it to 1, such that there is adoption of that of the digital technology. And then the VA implementations, it really has to go at pace with the system change. So for instance, in Myanmar, we started off with a pilot of 14 and very quickly ramped it up to 42 townships. And that represents 15% of the annual deaths. While in PNG, the process was a lot slower. And that's because of, a decentralized system of governance, the geographical difficulty in reaching. So one village to another, the health worker actually has to go by boat. So the pace of system change was a lot slower in PNG compared to Myanmar. And one needed to go according to what was acceptable to the health system. In terms of human resources for health, the absolute backbone and the crux of implementation, there was a variety of staff, and there is a variety of staff that can be trained to conduct verbal autopsies, from midwives in Myanmar to community health workers in Bangladesh, well, in Solomons, and nurses in PNG, doctors in the Philippines. We had to think about training of interviewers as well as supervisors. And the training had to comprise of training for VA, but also training about using a tablet, keeping it safe, and how do you transmit data from the village to, to the central server. The most important thing in training is also thinking about sustainability. So, it's well and good to do this large, amazing training upfront, but what happens to health workers when there is a turnover in the workforce? What happens after 6 months, or if there weren't too many deaths, they would have lost that initial knowledge. And so to think about refresher training needs in that large scale up and rollout is extremely essential. And also methods to incentivize people for VA training. One is to do verbal autopsies, and then also to incentivize them for training. So say, for instance, in the Philippines, the Ministry of Health is thinking about having CPD points for the doctors when they do the initial training and refresher training. And then in the last 2 years, especially these 5 countries saw the disruption of COVID-19 on collecting data for health, because suddenly all the priorities shifted towards COVID-19, and less emphasis was placed on collecting information on death. But it also introduced the possibility of using online training methods, which is appropriate for refresher training. It's just a bit difficult to do it in that initial training session. In terms of financing, this project was financed through two very generous funders, the Bloomberg Philanthropies and the Department of Foreign Affairs and Trade in Australia. But that initial injection really helped, bring the systems together and lay out the processes. But then there are also substantial ongoing costs associated with VA, which need to be thought of as the system is scaled up. And governments really need to think and consider these costs in terms of training, infrastructure, and very importantly, quality assurance. One way of doing this is also to tap into other programs. So if there is a training for a different reason, to introduce a module of verbal autopsy. And in terms of resources, if the tablets are being used for maternal and child health, perhaps we could use the VA app within that tablet. From when we looked at the study, it was also about funders need to appreciate that system change takes longer than the funding cycle period, more than those four, 5 years. And in a way, it was, sometimes you just hurry up to make things work, and those things are not sustainable in the long run. And so that's just something that we appreciated towards the end of this, end of these 5 years, looking back, that funding is never sufficient for sustainable long-term sustainability. Logistics gets really complex with scale, and one just needs to find a way around to get through those challenges. I talked about the turnover of health workforce in Myanmar. The midwives, there was a high turnover. In Philippines, the doctors they were transferred from one municipality to another, and the municipal health officer or the doctor wouldn't have been trained in smart VA. So we just had to constantly think of those things. There was a whole range of variety of IT related issues. And one really needs to think of knowledge exchange and transfer, that countries need to have that capacity built in for this intervention for its sustainability. And as I said, all of this would pretty much be useless if we don't have quality assurance throughout the entire process, right from the beginning of planning stage through to the scale. It's absolutely integral, and it needs to be built in through the different phases. There are several competing priorities, like the data collectors, the supervisors, even those at the ministry level. They all need to be considered carefully while planning a scale up or integration of VA into CRVS. So again, just thinking through all of these different domains of systems within VA and its implementation or its scale up in CRVS, these were the key recommendations that we came up with. That there absolutely needs to be strong governance and a business case to do verbal autopsies. And in most of the countries that we worked in, more than 60% of the deaths occurred at home, outside the hospital. So there was definitely a strong business case. Stakeholder engagement is key, and that's not just at the top level. We really need to have advocacy, because in systems where people are used to, writing cardiorespiratory arrest as a cause of death, to make people aware within the medical system and within the health system that actually finding out and knowing the exact cause of death is really important. So to get that engagement from the community through to the CRVS committee, that entire group is key. Understanding the current process And I must add the word, the true current process is essential. Not just talking to people at the higher level management, but mid and lower level management who actually have a sense of what's happening on the ground. Scale up and evaluate gradually. It's just really difficult to, in some instances, yes, it's easy for government to see the things scaled up, but then one would lose one of those important domains of quality, especially when scale up occurs too quickly. Technical support teams need to be flexible and work with the country team. Long-term technical support absolutely has to occur in the country, and knowledge exchange needs to be facilitated. In terms of sustainability, governments really need to be aware of the considerable ongoing investment, but also can minimize that or reduce that investment by combining things and not having parallel systems. And finally, documentation of lessons and results for VA are absolutely essential. There's so much that one can learn, especially in MINErVA. There's so much of rich knowledge and lessons that we all can learn from each other. So please document the work that you're doing and the lessons that you are learning as you go along in using VA. So the take-home message, if you haven't listened to the talk, this is the slide that I'd request you to remember, that VA is a validated method for understanding causes of out-of-hospital deaths. It's currently being scaled up as part of CRVS in many countries. Implementation is complex. It requires strong governance, technical expertise, a knowledge of the infrastructure, logistic, IT, and human resource needs, and requires evaluation as well as adaptation. And stakeholders need to consider the system level changes and the ongoing costs absolutely necessary to embed that intervention. And finally, when we have good quality VA implementation, it'll lead to improved causes of death, of community deaths. It'll improve health planning and finally better health outcomes. So there's nothing more important, as Professor Krishnan mentioned, than getting good quality deaths from the community. So I'd like to end by acknowledging all the country partners, the VA interviewers, and the communities, and acknowledge all the co-authors from all the different countries, the project funders, and also those who fund me, the Australian Heart Foundation and UNSW. And finally, thank you so much for giving me this opportunity to present this work, which is a collective work comprising of several thousands of people. So thanks so much.
Thank you, Rohina, for that wonderful talk. I'm sure we did not do justice by giving you 25 minutes to capture a whole series of experiences through multiple countries. You focused on the capacity building and the absolute necessity for a Minister of Health to buy in. I'm going to ask you a couple of questions based on your talk. The first one is, we all agree that this is an investment that government should make. And you showed clearly in your study that good part of your funding came from external agencies. But in the long term, the governments have to invest. So what was your experience in convincing governments to invest in this, and how much were you successful in getting them to put at least some money, if not the whole of money, into this?
Thank you for that question. So during the first 5 years of this project, most of the funding came from an external source. I think the investment from the government is in terms of their the infrastructure, the resources that are already on the ground. Now, I don't have the data around costing of how much the governments have invested in kind. There are some countries who are costing it out. There is a costing tool which was developed by Swiss TPH, again, Professor Don Di Savigny and Daniel Kobos. And so countries are looking at that. But the other thing is, when you present the costs to a country, they get really scared, saying it's too much of an investment and we don't want to get into it. So many countries have taken the approach to say that we have the available infrastructure. If there is that initial injection, we will take it on. And now, in some of the countries where the systems are a bit more matured, they are taking it on. So in terms of the investment now, it's more that the country's taking it on, doing the training, and we just provide some amount of technical assistance sitting on the side rather than driving it.
Good to hear that governments are at least considering investing. My second question is more on data sharing, the data that of cause of death which comes out of it. See, largely especially in the city that we work, we look at this more as a research paradigm, whereas this is to be seen as more as a surveillance paradigm, where the data is available in public domain, everybody knows it, where it can be. So how much of a progress did you make in converting at least cause of death data is not a research data set. It is a surveillance data set, should be in public domain. How much did you make progress in this one?
That's a great question. So this entire project was not looked at from a research angle whatsoever. This was purely an implementation study led by the government. And so if I could take the example of the Philippines, where they use Smart VA to certify deaths, the data actually goes into the Philippine Statistical Authority, which, at the end of the year, it becomes available. But for monitoring and evaluation, the Department of Health, especially the Epidemiological Bureau, which led the evaluation, they, the data were available. It was de-identified to then look at, what is verbal autopsy producing? What are the doctors saying and what's VA saying to look at agreement? So that part of it became, research, if you may want to label it, but it was more of evaluating, are the doctors using it? What's the agreement rate, etc. So the data sits with the country. It's publicly available when the government decides to publish it.
Were they really used to drive policy?
Well,
that is the ultimate goal for all
yeah. So I think at this stage, it's still quite early to see how that policy change occurs. But for countries to then say that, well, the undetermineds are going down from 40% to 15%, that will definitely, that's a huge, shift towards in the quality of the data, and therefore the confidence in using the data to drive that policy change. So I think right now we were in that implementation phase, and I'm hoping that this will then drive that next phase, which we all want.
Okay, my final question from my side. This is, you also have some experience in the Indian system, right? So what are the challenges if you have to do something like this in the Indian system?
Again, a wonderful question. Look, I think in the Indian system, it is feasible. It is feasible. The infrastructure is available. IT in India is, well, I don't need to say.
No, I'm sure we have the capacity. I don't think
Yes.
there's a capacity problem here. Yeah.
I think the issue would be around, putting in the systems in place for, say, training, for quality assurance, to make sure supervision is happening at the right time and in the right way, rather than reprimanding. It's actually positive supervision, which gets the health worker, be it A&M, ASHA, or whoever else, that the health system decides to train in this. It's about making sure that those domains that we talked about actually are willing and agreeable, because once we get the governance system in place, things then align quite well, because the workforce is willing. Once they know what's going to happen with this, they are willing. The initial thing, as you've led this work for such a long time, initially people say mortality, why are we doing this work? But once you tell them, then they are willing. And yeah, the workforce is the best part in this entire big scheme.
Thank you, Rohina. Do we have any questions from others, Maheshweta or Pradeep? Or should we go to the next speaker?
So we can go to the next speaker. We will have a question and answer session after that.
Okay, so please
you.
compile the questions.
Okay, yes.
So Biju, it's your call now. We will now focus more specifically on India. So we move from international experience to an Indian experience, and as usual, Kerala leads India in many ways, including in this. So Biju.
Thank you, Dr. Anand. And let me thank MINErVA Group for giving me this platform to share some of our work. Can you see my slides?
Yeah, just move to the slideshow. We are not seeing this as a slideshow.
Okay, I'll just give me a second. I hope you are able to.
Yes, this is good. This is good. Go ahead, please.
Okay. Thank you, Dr. Anand and MINErVA team for giving me this opportunity. And I'll be taking next 25 minutes to look at how we can look at the civil registration system in Kerala from a data science perspective. It's a work in progress, and along with me, Dr. Arun Mitra, Dr. Gurpreet Singh, both are PhD scholars with the Achyuta Menon Center, which is the public health unit of Srijitha Tirunal Institute in Trivandrum, and Dr. Shashi Kumar, who is the health officer of Trivandrum Corporation. We are working on this actually, so I'm happy to share you some of our initial results and thoughts on it. And I have organized my presentation like the idea of data for action and the maturity of the civil registration system in India and in Kerala. And we are taking a case study on the CRS data from Thiruvananthapuram Corporation and a bit on the data science perspective and our future plans. So it's all starting from this idea of data should be for action. So in India, as it was deliberated earlier also, in the previous speech also, we have a lot of potential for capturing data in the digital form. And a lot of computerization is taking place. Data, more and more data is getting into the digital form. But unfortunately, we are not using the data. So the data use that sort of there should be a sort of way of our life, and but unfortunately we are not used to that use of data thing. So that's where we are trying to bring in this data science perspective. And when I meant data science perspective, actually, what is data science? Actually, data science is a coming up field where we are marrying computer science, epidemiology, biostatistics, and the domain knowledge for reproducible research and for evidence-based policy making and all. So that's the crux of data science approach. So data science approach means we are not confining to our domain like in health or public health, but we are trying to see what's happening in informatics, what's happening in biostatistics, what's happening in other fields like in space technology or in satellite imaging and all, whether we can bring the advances in that field to answer some of our age-old questions. So that can be done in a sort of reproducible way, in a evidence-based way, so that it can be peer-reviewed and we can work on that. So entire work plan should be done in a sort of transparent way. So that's the essence of this data science approach. And a bit thing about civil registration. What is civil registration? We have seen with Rohina's presentation also, like civil registration system is a unified process of continuous, compulsory, and universal recording of vital events as per the legal requirements of the country. Almost every country has this civil registration system. And the history of the civil registration system in India dates back before our independence itself. And probably 1969, the Registration of Birth and Death Act was made it uniform and mandatory. And what are the main objectives? It has mainly three functions. One, the legal function, and second, the administrative utility, and the statistical utility. This is being collected and collated from all over the country in India. And this is how the hierarchy of the civil registration system functions in India. So it starts with the central level, the chief registrar, and additional deputy chief registrar are there, and district level is there, and in the local level, this is where I'm concentrating, because our effort here is like a data for action. So data should be used where it is being collected. Actually, if we have the potential of using data for interpretation or for health planning at the local level, that should be done. So the local registrar in a local body could be a panchayat, a block panchayat, a jilla panchayat, or it could be the state or central level. And at the local level, it's usually the health officer of a municipality or corporation, or the charge medical officer of the primary health center in case of a in the case of a panchayat. In Kerala, who is interested at the local registrar can vary from state to state. In Kerala, local bodies are interested with the registration of these vital events. So in a municipality, it will be the health officer who will be the registrar. So current maturity of the civil registration system in India, actually, you have seen that around 95% of facilities are regularly reporting. And in the rural level, rural and urban area, actually, we have a good proportion of facilities which routinely report on every month, and around 100% level achieved by. So level means level of reporting is achieved by 21 states and all. And recently there is an increase in number of births registered and increase in number of deaths registered, like 18-19, there's a 6.7% rise in registration of birth and around 10% rise in registration of death and all. And you can see that the level of registration of vital events is going up. And from, I don't have the figures for 2020 and 21, but it's going up. And when we are looking at various states, you can see that many states have achieved more than 90% birth registration and death registration. And some states like Kerala is on the top. Actually, we have a very good coverage of CRS. And this a pictorial representation of the coverage across Indian states. And in CRS in Kerala, so one of the early enforcers, like right after the Registration of Birth and Death Act in 1969, we implemented civil registration in Kerala. Now it is done through local governments and is fully computerized, because the Information Kerala Mission has developed a software called Sevana. You can see the snapshot of that. And it's given to all LSGAs. There are 1,200 LSGAs, 1,200 LSGAs in Kerala. So now issue of certificate is also computerized. So we are providing digital certificates. And the state government, actually, it comes up with state level reports, but usually these reports are quite delayed. It won't come on time. And these reports talk about state-wise figures and at the most some district estimates and all, but it's not suitable for local action. So that's the point here. And this LSG can, although it's implemented through the local bodies, what's happening with the local bodies, these local self-government institutions, they can take output only as PDF formats. And they don't have any competency for data analysis. And you know that in a panchayat or in a municipality, the officials are preoccupied with many other pressing issues. So that is where we thought about whether the data science approach can be used to help the officials and the functionaries of local governments to use this data. So this is the question. And what is the data science approach? From the very data entry to data collection and processing and validation of data and integration of data with the other outside sources, and analysis and dissemination in way of good graphical visualizations, and interpretation and communication of entire data can be semi-automated and can be done in a very transparent way and a reproducible and scalable way, so that it can be replicated by other governments or other agencies. The potential is that it can encourage data use policy and improve data processing, validation, efficiency of the system, and it can integrate data from other sources. In this example, I'm just presenting this case study here. We are taking data from a NASA site for population projection. We are getting data from NASA sites, and we are trying to integrate with the data which we are collected from local bodies and all. And timely actionable evidence for public health interventions are possible. More than that, we can have a spatial epidemiological analysis also tried out. And transformation of data from PDF into analysis-ready formats can be done. And that's also one of the achievements of the informatics now. Probably we should start using that utilities. So the case study I'm presenting here, the CRS from Thiruvananthapuram Corporation is having a population of over 7 lakhs, and it has a square area of 310 square kilometers, and is quite literate. Like literacy rate is around 95%. Male female difference is not much there. It is subdivided into 100 wards, and here the health officer, Dr. Shashikumar, is the registrar for registration of birth and death. And corporation officials, actually the registrar himself can take output from the cause of death in PDF formats only. You can see that this is the how is in Malayalam, that is in the cause of death is scored in Malayalam. But we have all the details, but I'm sorry, I'm just haven't masked the addresses and all. Just for this presentation, I haven't done it. But you can see that there are around 16,000 deaths in 2017, and it is given in around 3,361 pages like this. And if you take 2018, there are around again 16,000 deaths and around 3,369 pages, and 2020 around 3,000 pages. This is the format. They won't get, they're not able to get it in spreadsheet format at all. But what we have done is that we have analyzed this one using, I'm looking for a size, sorry, that slide is missing. But what we have done is that we have taken this PDF formats and we have converted that into spreadsheet. And then the spreadsheet, we again use data science approach to tidy the data. And then we have integrated data from other sources. And then we have done this analysis at all. And we quickly did this analysis. And over the years, actually, this is an analysis of around 48,000 deaths, over 48,000 deaths. Actually, we quickly look at the age and sex proportionate thing, and you can see that on 2020 there is a slight decline in the number of deaths, maybe because of that COVID lockdown period. That is what we have observed in Kerala. And we can do this kind of quick analysis, age distribution of the disease, like NCDs. We have this much of death, and the mean age was 61 years, and this is how it got distributed. And for senility, you can see that average age is 81. Whereas road traffic accidents, the average age is 45. You can see that it's distributed across all the things. And this maternal and child health issues in infancy and then other ages we are seeing. And suicide death, the average mean age is 46. And over the years, we can see how the death, the proportion of deaths vary and all. You can see the heart diseases, they continue to be the leading cause, and others is some of the sections from the Malayalam coding. We have just tried to recode it into English formats, and we couldn't code many of the time. So that's why this others component is coming. That's the second most prevalent one. But pneumonia, you can see the pneumonia deaths were around 700s, but in 2020 it has gone up mostly because of the COVID and all. Again, I've just looked at with the cause of death, what are the leading cause of death over the 3-year period. And cause of death by age group, we have seen, we have analyzed, and you can see the under 5 miscellaneous categories there. And NCD include congenital heart diseases and also, so that could be the second most cause, but infections come there. But when it comes to elderly, like you can see that heart diseases and heart attack, they are the leading cause, followed by other NCDs, and then the miscellaneous category, and infections around 9.9%, and senility comes there. And with this quick analysis, actually, we'll be able to create this kind of maps, which you can see that whether there is any seasonality of deaths. Like, for example, COVID, you can see that COVID started in 2020, started and it went up like this is the thing. And dengue, actually, we can clearly see a correlation with the rainy season and all. But with diabetes, we are not seeing that and all. But leptospirosis also we see and all. So it's kind of quick analysis is possible. COVID, again, is an expanded view of the earlier slide. And not only that, I was telling you that we can do spatial analysis. Actually, we have distributed the death. Although the death is getting registered in Trivandrum Corporation, but deaths which occur in the nearby panchayats also get registered here, because we have major hospitals in corporation and all. So when we are just looking at the overall deaths reported, it got reported in nearby Grama, Panchayat or rural areas also. But within Trivandrum, what's happening here? Right? This true death. And we have done this true death rate per 1,000 population. How is the death varying? For that, the population for 2020, we have extracted from this socio-economic data appraisal committee that the NASA provides a raster projected population figure for 2024 all over the world, and we have extracted that from NASA website, and we have calculated the population and all. So that's how we have done this true death rate and all. And this is the proportion of true death rate. And when we are looking at the under 5 mortality numbers, mortality rate, when we are looking at per 1,000 population, you can see that most of the death or most of the higher proportionate death are occurring in the periphery. But when you look at within the corporation, what's happening, we are seeing some risk areas there and all. And this is distribution of elderly death. Elderly death, you can see that even at the district level is concentrated in the city area. And this is for heart disease and heart attack. Actually, there also you can see the concentration is in the city area. So now looking at the road ahead. So data science approach is, we feel like it's the way ahead for this kind of analysis, because CRS or civil registration system is doing fine in Kerala, and Panchayat are doing it, and they are able to access the data, but unfortunately they are not able to access the data in the spreadsheet format and LASIL format. But even if they are able to get the PDF format, using this reproducible algorithms, we'll be able to help them out. These algorithms are based on open source technology. They are highly scalable and customizable. I'll just give you some examples of that. For example, the code which we created this way is done in R. Using RMD or R Markdown file, and we can come up with this kind of a output. It could be in PDF, it could be in Word, or it could be in HTML format. And for example, once we create such codes, the output could be that note there are 153 addresses which were not geocoded when we tried 2020, and there were 175 panchayat and 15 blocks in Trivandrum district. This kind of things, it can vary from, when we are talking about Trivandrum district, this one and all. When we are talking about Kollam district, it can be automatically calculated and the figures can come here, provided we give this kind of codes and all. So that's what I meant is scalable and reproducible and all. And we are using free and open source software for this and all. As are free and open source software. And with this, we are developing this one, and our idea is to provide that to the corporation, municipality, so that they will start looking at what's happening in what's the pattern of death occurring in their local body over every month, and that they can use it for presentation during their conference or during their corporation meetings at all. And that's in nutshell what I have to tell you and all. And if you are interested to see how we are doing this one, actually we are having an R workshop coming up. And so in the R workshop, we'll be taking the techniques of doing it, how we can use open and freely available software to advance data science approach, which is a reproducible approach to go ahead. So let me stop here. And
Thank you, Biju. I think your presentation dovetailed into Ravina's very well. Ravina focused more on how to generate data, putting in place systems to generate data, while you talk more about what to do with the data, how to get the data and people to work on the data. But one question from my side to you, Biju. As of now, it appeared, at least to me from the writing, that you are sort of an intermediate, you are an external agency who is doing this in order for the data to be used by the system, because system does not have the capacity, as you rightly said, the panchayat systems don't have the, do you think there is a much more sustainable solution there? Or for example, or you will just write a program and everybody just given a software program and they take out an output and still they would have the capacity to use it?
Yeah, I think so, because when we are looking at the cause of death, you can see that quite a lot of a major chunk is miscellaneous or others and all. And because nobody is looking at this CRS data or cause of death that way, that could be one of the reasons why there are many missing links and all. So once we enable or once we improve the capacity of just share that with the local bodies, like in Trivandrum corporation, that's what we are planning to do. We will ask the health officer to present that to the corporation members and see which are all wards have higher child death, or which are all panchayat have accident, which are all wards have more accident death and all. That can sensitize them and they can think about some action, and that way it will have a cascade effect in the sense that people will be encouraged to give much more reliable cause of death and all. But it's not a substitute for medical registration of death and all. But for local bodies, it's being collected and collated in all the 1,200 local bodies in Kerala. And why don't we encourage them to use that? So that's...
Okay, good. Maheshweta, how much time do we have for questions and answers from the other panelists?
Sir, we have 10 minutes question and answers, but we can have another session on the MCCD of state of Uttarakhand by Dr. Mahendra Singh. So we can do that session and then have a question and answer session.
Okay, so Dr. Mahendra Singh.
Yes, sir.
So Dr. Mahendra Singh is an associate professor in the Department of Community and Family Medicine, Rishikesh. And he will be presenting on the MCCD status in Uttarakhand. Over to you, sir.
Sir, screen is visible?
Visible, you have to go to the slideshow mode.
Yes.
Yeah, that is fine. Please go ahead.
Basically, I give the responsibility of vote of thanks. Before vote of thanks, actually, I want to just focus on the Uttarakhand is the one of the states which participating in MINErVA project. So I want to just brief about the what is the current status of the MCCD, so we can realize the what is the how much MINErVA is the play important role in our public health perspective. This is our question in mind. How many deaths were registered in any state like Uttarakhand? How many deaths were registered within a notified period of 21 days of death? Among registered total death, how many deaths were medically certified for cause of death, means the covered under MCCD? And among medical certified death, what is the quality of the final of our objective, that field MCCD forms? When we see the data regarding Uttarakhand states, this is the latest report, which is belong to year 2019. In Uttarakhand, total registered death according to civil registration latest report 66,313. And among these, 50% death were reported within 21 days of death, means 33,615. And when we see the latest report on medical certification on cause of death 2019, in Uttarakhand, there is a 1,216 the hospital providing IPD facilities, and among MCCD project for medical certification of cause of death, 36 institute have to cover under this MCCD, and 2019 only 23 institute submitted their MCCD forms. And when we compare with national figure and other state, the Uttarakhand state rank of 32. When we see the total registered death is 66,300, only 5,876 deaths were covered under medically certified death. That is the percentage of only 8.9%. And national level, this is also very low figure. Only in India at national level, as per latest report, according to 2019 medical certification cause of death, only 20% death were medically certified. And when we compare with the top to bottom level, the every death in Goa states, and out of 100 deaths were medically certified in year 2000. That is the goal. When we see the Goa is the small state, and when we see the Uttarakhand, in Uttarakhand only 8.9% death covered by medical. So this is the big gap. This is our task. So the task is every death should be registered outside hospital, in hospital. In hospital is already registered, outside hospital. After registration, the task is every death should be certified for cause of death. So there is and MINErVA is the step to link with the not only for certain for medical cause of death, mainly focus on the maternal mortality, and but biggest goal is the MINErVA to cover all that for a cause of death, and that data should be a quality, complete quality data. So Uttarakhand is just my purpose of these slide is there is many goals we can do a collective works. This is the small states, like we can work in every state with our network partner under guidance of our AIIMS Delhi Professor Anand Karsan. So this is the small steps and biggest journey we have to achieve. Thank you, sir.
Thank you, Mahendra. I think you have your task cut out, both you and Pradeep. Definitely Uttarakhand is a challenging state, given its hilly nature. Though I was surprised to see only 26 facilities being listed for MCCD, because when you assume even private sectors will have to do it, right? So that seems to be too small a number. That there would be more than that hospitals in Dehradun itself.
Yes.
That they are reporting. So that seems a bit surprising, the low numbers of hospitals reporting in MCCD. No wonder you have very small coverage of MCCD. But anyhow, so I think Kerala and Uttarakhand present contrasting examples. Definitely the Biju and his team, though he talked more of CRS, not of MCCD, but they are definitely moving far ahead, and I think we have a lot of catching up to do. Thank you, that Mahendra, and now we will take up some questions which have come up.
Yes, sir. So we have over 80 plus participants, and they have hopefully they have gained a lot of information and knowledge regarding the MCCD, the CRS, verbal autopsy, and MCCD inclusive. So here there are a few questions put forward by them. First is, what is the percentage of deaths in urban and rural area which occurs at home in India? So over to the floor.
So anyhow, I think in simple as we know that about 20% of deaths in India are medically certified. So one would assume that would be roughly equivalent to the number of, and as we just saw from examples from Uttarakhand, even that's not necessarily true, that not everybody who dies in the hospital gets registered as a part of MCCD. Therefore, there would be more, but definitely at least 20 to 30% of people are dying in the hospitals. We can look at the other aspect.
Very true, sir. And we still have a long way to go. So the next question is to Dr. Rohina Joshi. And that is, how was the quality of the VS shared in the study?
Thanks for the question. So the way we looked at quality was, one was there were supervisors for a certain number of community health workers or interviewers who would look at the data as it went through. That was one level of check. But then once the analysis takes place, we would then look at the causes of death by municipality or by smaller regions, and then would find out, okay, if there are a lot of undetermineds, then there should be an issue around training of the health worker or her interpretation, or are these all older age group of people who are dying where it's multiple morbidity and it's very difficult to then have one particular cause of death. So across the level, right from training through to getting that initial questionnaire and then looking at the causes of death, the quality was embedded within that process. Thanks for that.
Thank you. So as a multi-level procedure, it does require a multi-level quality checks at all its levels. So definitely being embedded inside the study itself is a big help to the final quality checks. So now coming to the next question. This is to Dr. Biju Shomen, and that is, what is the robustness of cause of death information in CRS data in Kerala, and any intervention done so far with this aspect?
I won't vouch on that. It's equally bad as in other states. Quite a lot of deaths are recorded as heart attack or cardiopulmonary arrest and miscellaneous, etc. And for the past few years, the government is insisting that cause of death should be captured in Malayalam. So that is adding to the confusion. So some Malayalam terms are there and all. But a good number of death on the cause is written as pending verbal autopsy, pending autopsy and all. So it's equally bad as in other places. But there is no efforts to correct that as of now. But we hope that if we can engage the panchayat authorities or the local body authorities in showcasing or to visualize the cause of death in their area, that will prompt some action. And then we can encourage the corporation and the local panchayat to take up the initiative. That's what we are hoping for.
Yes, sir. And so the next question is again, what is the quantum of delayed registration in CRS in Kerala?
Yeah, actually, for the analysis, we have excluded the data, the death which got reported beyond 21 days. Actually, it's coming to around exact figure, I don't remember, but around 20% out there. And when we just geocoded the deaths which got reported into Trivandrum Corporation, we found that around 73% of death are coming from Trivandrum district, and rest of the many deaths, the address is in Tamil Nadu and other districts they're also getting reported here. But the delayed reporting is around 20%, and during 2020 probably we'll have more delay in registration.
Thank you, sir. So now a question to Dr. Mahinder Singh in specific, and anybody can answer also. What was the quality of the medical certificates?
Regarding medical certificate quality, we are working on that. In 2019, near about 5,000 deaths were certified in Uttarakhand state. So we just submitted a research proposal for to check the quality of that MCD, and we working with other hospital and all three medical colleges of Uttarakhand to check that, and then we will try to publish under guidance of that MINErVA project.
Thank you, sir.
At present, there is no data on the quality of the MCD in Uttarakhand specific. Yeah.
Yes, sir. We have a long way to go in MCCD, as we can see. So, yes. So that was quite an interactive session, and we hope to see more questions as they come. But till then, we have posted a feedback form over the YouTube link, and all the participants are requested to just give us a feedback for how well we were able to communicate and how good the information came to you. So after we get the feedback forms, we will be providing you with the e-certificates. So we expect good information, good feedback forms from all of you for the same. Now the floor is open for the discussion. The speakers, if they want to say anything to the participants, all are welcome to.
Yeah, can I actually? I'm thanking you once again for giving this platform. I think those of us who are interested to work in public health, we should start using this data science approach. Especially, we should harness open and free softwares. So using open and free softwares will help. Like our plan actually is to analyze the death in Trivandrum Corporation over the last 10 years, and then come up with a template which we'll be able to install into the computer of the local bodies, so that the medical officer himself will be able to run it, because it's semi-automated. We can make it semi-automated. And once we do this for Trivandrum Corporation, and we can replicate that for the other corporations and the local bodies and all, because we are using free and open source software, there won't be any additional expense for that and all. They all have computers, and they all have this data which they can download as PDF from the Savana portal. They have access to that, and they can start looking at that data. Probably if they need some sort of technical help, we can engage with the local medical colleges as Mahendra Singh is doing actually. So that is the way ahead. And in public health, we should start using open software for our analysis and all. We had to dump SPSS and all and come to R.
Thank you, Biju. I think we will look forward as not only because you see also MINErVA is going to look into this aspect, and we did have this discussion. We look forward to your continued guidance and support to take this forward. Ultimately, this data has to be used for action. That's the whole thing, purpose. So both at local level as well as at higher levels. So thank you, and I think we don't.
So, Dr. Rohina Joshi, please. You have.
No, thanks for that. I just had a question for Dr. Biju in terms of the verbal autopsy tool used in Kerala. I'm sorry if you mentioned it. I just wanted to clarify, which tool did you use?
No, this is not from verbal autopsy. Actually, verbal autopsy is another project of ours. We are using Smart VA. Actually, we have customized that, and only now we got permission. So we'll be doing that in Trivandrum as well as in Wayanad. So we want to see whether there is a difference. For that, we are using Smart VA, and we have translated that into Malayalam and back translations.
Thank you.
Okay, I think Mahendra wants to give vote of thanks.
Yes, sir. So thank you, everyone. Dr. Mahendra Singh, on behalf of MCCD, one of the network partner institute of MINErVA project, under umbrella of AIIMS Delhi, national leader of MINErVA project, with our local organizing team led by site PI, Dr. Pradeep Agarwal, and co-PI, Dr. Yogesh Baurupi, extend very hearty gratitude to all the dignitaries of this webinar. First of all, I would like to give my hearty vote of thanks to our Honorable Director, sir, for their constant support. I would like to thank Dr. Anand Kishan, sir, Professor, Department of Center for Community Medicine, AIIMS Delhi, and National Leader of MINErVA project for minute-to-minute support and guidance. Thank you, sir, for your thought-provoking and interesting input and guidance. Sir, constant encouragement had made this first webinar of MINErVA project a huge success. I would like to convey my heartfelt thanks to Professor Biju Soman from Kerala and Dr. Rohina Joshi for taking very wonderful scientific session on very important and relevant topic under this MINErVA project. I am also thankful for staff member of our institute, administration staff, IT support in general for supporting us with all possible logistic support towards organizing this event. Thank you to all. I hand over to Dr. Pradeep Agarwal, sir, for final remark.
The final blessings of Anand sir is always awaited for everyone.
No, I'm not going to bless you. I think that will leave to others to do. But thank you. I think it is always a team effort, and I'm happy to be part of such a large team and such an enthusiastic team. And I'm sure we will work and see the progress of this, and something that we all want, that India should have a top-level mortality surveillance system. I think our efforts should be towards that, and I'm sure we'll make it happen in near future. Thank you.
Thank you.
Thank
you,
you,
everybody.
speakers.
For a brief period, I saw Ayon in a military camp.
We need to have a special
We
mention.
need to have, yes.
Dr. Harshal Salve sir and Dr. Ayan Gupta, and he have been a backbone of putting up these webinar series also.